Okay, the iPad is not here yet. Controversies. Oh, well, first of all, welcome all of you. My name is Dr. Sonja Settler, and I will introduce our wonderful first speaker for this session, Controversies and Conversations on the ECM Wars, Regeneration, Fibrosis, or Fiction. So I think we have a fantastic session to come, and the first speaker is my dear colleague and friend, Dr. Diane Duncan from the US, and she will speak about the ADM. She will explain that more to us. We are missing here our schedule at the moment. Thank you, Diane, for being here, and thank you. You're always very scientific. I'm very curious what we will hear from you.
Okay, thank you.
This is
do you want to start my slides?
Kind of, session that we arranged to be like more talking instead of more interactive.
I need somebody to start my slides.
Yeah, we managed the time. Right. But this is also the new highlight session that we try to put more on the IMCAS Asia. So I would like to invite every one of you, like, come every year. We try to make up something interesting like this, this is a controversy session, and we're gonna have like conversation from all the experts. All the experts from all around the world will come, and we're gonna do like very scientific talk on our.
Okay, we're going to go ahead and get started. This afternoon, I'm going to be talking about ADM, acellular dermal matrix, and the connective tissue matrix, and some of my thoughts from 25 years ago till current studies. So Achima assigned me this interesting topic, and I wanted to share with you that my very first publication, peer-reviewed publication, was 25 years ago in ASJ. I published an article on acellular dermal matrix for breast implant rippling. And the reason that I did this is at the time, we were only allowed in the US to use saline implants. They had just taken gel implants off the market. And of course, so we had a lot of rippling, especially in that lower and outer pocket, because there was basically no soft tissue cover. So my next article, again on ADM, was particulate alloderm for a more permanent solution for lips and perioral rejuvenation, because at the time we only had collagen filler and it only lasted 3 months, and our patients were super unhappy about the temporary nature of the fill. This was a little challenging to do because I had a sheet of dermal matrix that I had to turn into particles so that it could be injectable. And so I had to chop it up with either a neurosurgical rongeur or tiny scissors in order to get this product through a cannula. Because of the labor-intensive process, it didn't really catch on. So fast forward to the current day. So now the Chinese and South Koreans are making what they're calling a micronized ADM, and they take the cells and DNA, lipids, etc., especially the antigenic components out of the dermal matrix and retain collagen, all types, the GAGs, proteoglycans, and the ECM architecture. So this will be more of a micronized load-bearing scaffold. They lyophilize or freeze-dried it, and this makes it more mechanically fractionable or fragmentable. The fragments are then either cryomilled or passed through a sieve in order to sort out the particle size. One of the interesting things about micronized ADM for cosmetic injection is that though there are multitudes of uses and areas that you can use this for, such as acne scarring, localized depressions, nasolabial folds, and wrinkles, it is still, the data on aesthetic use is still pretty new. So reconstructive use, there are quite a few articles that show longevity as far as wound healing, rapidity of wound healing, but the only real valid use of this article on development of MADN was a split-phase study on 16 patients with 48 acne scarring lesions. And while the data showed that there was pretty significant improvement in both the ASAS, or the acne scar scale, and the ECCA, their data was only at 3 months, so we don't really know anything past 3 months what the longevity is. If we look at how skin and adipose matrix age, we find that both of these are really quite similar. We used to think, of course, that the aging skin lost collagen and elastin, and that's not quite true. The collagen type 1 does diminish. The ratio of collagen 3 to type 1 also diminishes. The elastin doesn't really decrease in amount, but it does decrease in character. It's not as well organized, and the tissue becomes more stiff and has less tensile strength and a little bit worse shear force. So if we look at the proteome of aging skin and the proteome of the adipose matrix, we see decreases in very similar proteins, but the fibrillar nature of the collagen diminishes, and you'll see a decrease in integrins, which are important for adhesion kinetics, a decrease in decorin, and all of the GAGs. Then this is very similar, slightly different in texture and in the adipose matrix, but actually very similar. One of the older proven concepts beyond the micronized ADM is injectable adipose matrix. And this has been around in the US, FDA approved, for about 7 years. And this is a histological examination or example of the ADM at a few months, weeks post-injection on the left. You can see there's only regeneration of adipose tissue fairly near the base of the epidermis. But at 12 weeks, you can see full incorporation and some neoadipogenesis. The nice thing that I like about this particular product is that if you do fat transfer, then you know that this is a broad, soft fill without a lot of structure. But the AAM, adipose acellular matrix, actually will give you a load-bearing scaffold and a little bit more sculpting and definition of the face. So when the face needs a jawline or cheekbones, or even an area where you want, in the past you would have used a small chin implant, then this is my go-to solution. Kokai, et cetera, in 2020 showed almost 100% replacement of this AAM with autologous or endogenous fat. And so there's not really the loss of fat grafting. My personal ratio or percent take of adipose transfer is about 66%. And this is pretty close to 100%. The nice thing about this injectable is that it lasts a really long time. Basically, for the life of the patient, they will have augmentation. Patients get anxious about the permanent nature of this particular injectable. I've never had a patient be disappointed except for they had hoped for more volume. Now, if we look at the matrosome concept, and this is something that Ting Song basically introduced me to, is that this is something, the matrosome is not really exosomal or secretomal or regenerative in and of itself. The matrix proteins, or the matrikines, are products of cleavage by proteoglycans and proteolytic enzymes, basically in the third stage of the development of the wound healing process. So initially, of course, you'll have the hemostatic phase. This is mostly a growth factor thing. And the inflammatory phase, you'll see the effect of a few exosomes, cytokines, chemokines, et cetera. But the matrosome is basically best expressed at the beginning of the proliferative phase, and you don't have any matrokines without your MMPs and TIMPs, and these are also signaling agents as well as structural substance. So if you look at exosomes, basically they're a signaling agent, but the matrokine is the structural element. You're not going to get restructuring with any exosomes or signaling. Basically, that just tells the existing cells what to do. So one of my new projects, I ran the proteome of the adipose matrix in April of 2026, so not too long ago. This is something that I did in conjunction with treating with energy-based devices, because I'm looking at how energy-based devices can restructure and amplify the substance or production of substance of endogenous tissue without causing fibrosis. So my premise is maybe a little bit primitive, not yet quite as elegant as I'd like, but I started out treating tissue with mechanical only. Of course, I got a control sample. Mechanical only, hydrated or tumescent tissue versus dry tissue, and an radiofrequency wand that goes underneath the skin at very low power, medium power, and very high power to see at what level of thermal and mechanical stimulation we needed to perform in order to get regeneration versus fibrosis. One of the things we found is that the collagen analysis is most important. The most highly expressed protein is COL1A1, which is, of course, your basic collagen 1. The collagen 3, the ratio is important, but the most important thing in the regenerative collagen arena, and these are all the top collagens in the adipose matrix, is surprisingly collagen 6. So the next thing we had to do is look at all the proteins that were important in regenerative expression. Another thing we looked at was scanning electron micrographs and how the adipose matrix responded to all of these energy sources. On the top left, you can see a control of youthful fat, and this is basically neatly lined up adipocytes that has a blanket, so to speak, of fine, loose areolar FSN or fibroseptal network. The aging stroma, you'll see a little bit more irregularity, some holes in the fat that are due to a combination of atrophy and basically erosion of both the adipocytes and the fibrous structure of the supporting FSN, which is a three-dimensional, not unidimensional thing. In tissue that was treated with a power of 11, which is basically your therapeutic level, you can see that this kind of knits together in almost a purse. It's a three-dimensional loose coagulation, but there's still some space. And we want this space because soft, pliable adipose tissue rather than stiff tissue is going to exhibit better tensile strength. However, the setting of 15, which is the highest you can go, you can see a coagulum with a lot of almost fibrosis of the fibroseptal network. Another thing that's interesting that we see with power variations is in this picrocereus red stain, the immunofluorescent histology. The low energy treatment right in the center is the ideal of where you want to see your collagen ribbons a little bit more close together, but not in a coagulum as it is on the left. The herringbone pattern is characteristic of a fibrotic, basically coalescence of collagen tissue, which no longer has any distensibility or pliability, and the fibers on the far right are basically thermally untreated. Lastly, I'd like to introduce the concept of sliding ptosis, and those of us who are plastic surgeons know that as soft tissue ages, you'll see skin that hangs down below your adipose matrix, and the adipose matrix is inherently adherent to the deep fascia. But this is an uneven expression, and so youthful tissue, if you manipulate a skin and fat layer, they're almost one tissue, they're very cohesive. But what happens with aging is the integrins and adhesions kinetics will change. And so you see the patient on the top is 40 years old. Same woman came back to see me for something else at age 44 and wondered why she lost her jawline. Well, you have focal bone loss in the region of the gonial notch, the prejowl sulcus, the mentum. Niam and I were just talking about how the force of the mentalis musculature will depress or retrude the region of the mental prominence or the front of the bone. And you also see loss of height, but thickening of the mandible. And this, of course, is expressed, there's no load-bearing scaffold anymore. The connective tissue of the muscle makes it not as cohesive, and so there's some laxity, maybe not loss of volume of the muscle, but definitely some laxity. And because the adipose and skin become more detached, and the tissue is still adherent to the fascia, but not as much as it was in youthfulness, then we see the sliding ptosis, or drooping with time, that in the past we've just repositioned tissue surgically and haven't had a good non-invasive solution for. And so these are the proteins that you see that will have a role in adhesion. And so by looking at the proteome, if we see a decreased expression of things such as laminins, collagen 3, fibronectin, and decorin, then we know that this is part of the expression of sliding ptosis. So in summary, and these are controversial questions that we'd like to address, are biostimulators creating fibrosis or clinical improvement, or maybe both? Can energy-based devices be precisely tuned to get the proper thermal, mechanical, and impedance control that would steer tissue towards regenerative and non-fibrotic responses? Can biological regeneratives improve the content of the matrix, or are they just signaling agents? And to me, the big question surgically is, can we substitute a non-invasive or minimally invasive approach for skin excision? Thank you for your time.
Thank you, Diane. So for the sake of time, I think we keep questions to our last part at the end. And as Achima is not yet ready with her lecture, I would like to ask Tingsom first to come up with your lecture on energy-based devices. Yeah, interesting. Right. So I think, Diane, your questions at the end were perfect. So we start off with different modalities, and at the end we can discuss.
Okay, so I think some of you have seen me showing the video earlier about extracellular matrix. This is my conflict of interest statement. So basically, when we look into the extracellular matrix, we used to think that it's only in certain areas. But this is a video done by a plastic surgeon called Jean-Claude Guimbach-Tu. He has been videoing all the connective tissues in a living being for the past 30 years. The thing that we saw in this video is really changing the way we look at extracellular matrix and our living tissues, because for the past 500 years, we have been studying our anatomy based on cadaver, which is post-mortem, which is a lot dehydration. We basically are studying the grapes with the raisin. So basically, we don't see this connective tissue in there. What he did was, because he found that when he did tendon transplant, the tendon survived when he harvested together with the extracellular matrix. And what he see in these endoscopy videos are connective tissues that are living. They continue to move.
And every time they move, they go back to a different position. That means they are not always the same. The second observation that he found was, we always thought that all our tissues are filled with cells. Fat cells, muscles, is layered by layer. But in real life, what he found out, this is without putting air in there, he saw that the cells are only in small pockets. That means in our living tissues, there are more space than the cells itself. And in these cells, you can see this is the skin, and directly down under the skin, this is the muscles, and you can see how it's intertwined, and there's a continuum of connective tissues. These are the fat cells, and they are dehydrated. These connective tissues are made of collagen type 1, type 3, type 4, and type 6. So basically 4 types of collagen that builds up. And these collagens are wrapped up by your glycosaminoglycans. And the glycosaminoglycans allow it to glide and continues to bring all our connective tissues and pressures in our living tissues. And therefore, it explains why our skin quality depends on everything beneath them. And whenever we push or pull it up, we are actually manipulating these connective tissues. In the cellular level, these connective tissues are actually connected to cells through your integrin. These connective tissues pass through integrins and translate into, it's connected to our cytoskeleton and into our nucleus and gives signals to our nucleus to produce certain kind of proteins. So this is a really interesting network of connective tissues that actually allows us to pass energy, signaling, cells, and also you will realize a lot of blood vessels actually runs around together with connective tissues to the cells. And what is interesting is, once in a while, you can almost see cell migrating towards these connective tissues. And therefore, our body is no longer just packed with cells, but it's a tent. These connective tissues actually shape how we look like and give us volume. So we don't age because we lose volume through losing cells or tissues. We lose the volume because these connective tissues are looser. They are not as tense as before. So go back to the same question I asked earlier. Is the bone supporting the body, or is our body supporting the bone? Let's say if we don't have these connective tissues, our bone will collapse on the floor. Is this hydraulic system that holds the muscles together? We call it tensegrity. As part of aging, because this connective tissue actually age, it actually slowly collapses. So the whole concept of matrix itself is way deeper than your skin. So we couldn't really see through histology because most of the time it's dried up. All we can do is to do endoscopy into the tissues, and you realize there's lots of hole in there. There's lots of space. And part of aging itself is whenever there's a collapse, there's hardening of this matrix, that the lymphatic system fail, you have edema and inflammation. In fact, you can almost see bubbles in these connective tissues. Of course, when there's fibrosis, you have scar tissues. And with aging, with glycation, the whole glycosaminoglycans, due to the insufficient of your fasciocytes, that you don't have enough lubricants, that they start to collapse. But what happens when we cut through the skin? This is what he shows. By cutting into the skin, of course, you have a lot of blood flowing in, and together with the platelets, you actually create the fibrinogen, create fibrins, you have the coagulation phase, and then they start to stimulate, to build up a condition that tries to hold the tissue back to where it is. But this time, when you go back to a scar tissue, even if the scar is healed, when you go back down in, it's never the same anymore. So every time we actually disrupt connective tissues, we disrupt the matrix, we are creating a new type of microenvironment in our tissues. As you can see here, it's all adhesion, there's a lot of fibrosis, they are mainly built up with lack of a lot of flow, a lot of energy. Therefore, what we see is tissue adhesion, and most of the time we get pain. So studies have shown if most pregnant women who have cesarean section will end up with back pain, not because that it was the scar, but because it disrupts the flow of energy in the body that translates to a lot of pain. This is why it's important, because whenever we have scar tissues, we have gluing of our connective tissues. And therefore, ECM health is so important. With energy-based devices, if we overdo them, we can get scarring. Even though it heals on the outside, doesn't mean it heals in the inside. And this is why we see a lot of energy-based devices. For instance, if you do too much of lasers, you get hypopigmentation. You get hyperpigmentation because of scarring. And therefore, energy-based devices, we have to do just enough to stimulate the tissue without creating overstimulation that gives us all types of scars. We have seen with energy-based devices and even fractional CO2. All the ablative lasers that we do, we think we are actually reducing scars, the subcisions we are doing. In fact, we are creating more scars to the tissues. But are there other EBDs that actually helps in regeneration? Yes. We also see energy-based devices that helps to reduce melasma, improve the condition of melasma, improve redness, improve scarring, and improve a lot of our tissue, perhaps redness and scars. We have seen acne scars improve. We have seen skin quality changes because it actually improved the connective tissues, and we regain some elasticity. Our connective tissues are not more hydrated, they are actually more agile, they actually gives us some kind of youthful sort of regeneration. This is one of the devices that I use for a lot of people with redness and also scars. This is a device that using electromagnetic field. Electromagnetic field and a lot of devices that uses vibration helps us to reconnect. So by loosening up, because just now when we see these connective tissues, they are continuously moving. If you use energy-based devices that helps to stimulate and vibrate these connective tissues, you reduce scar tissues. This is, again, electromagnetic field without any injection can actually reduce hypertrophic scars as well. And what we see with things like pulse radio frequency, electromagnetic field, gives us reversal of all this redness. This is abnormal blood vessels on the surface, and also reduces scars. And I think this is where we will want to change our mindset, that not always when we want to treat scar is going to ablate them. Maybe we need to treat them in a more gentle way to allow our connective tissues to get hydrated and healthy again. And sometimes by stimulating muscles itself also helps that. This is by using a lot of devices that helps us to stimulate muscles, also helps us to improve the connective tissues. So even with EVDs, we'll try to not to hurt the matrix. Don't try to overstimulate them, because stimulating fibroblasts is just part of the story. In fact, we should actually allow the cells called fasciocytes to lubricate and create more glycosaminoglycans, and the decorin to work so that we have a more structured and healthier ECM. In the end, feed your tissues, vibrate them, and allow them to regenerate. With that, thank you very much.
Thank you so much, Sing Tong. I'd like to introduce our next speaker, Dr. Niham Korda, and she's going to talk to us about CAHA, and how the CAHA and biostimulatory injectables will continue our discussion.
Okay. Good afternoon, everyone, and thank you for inviting me to join this session. And I was supposed to be a little bit argumentative because they want some good discussion. So we're talking about CAHA. This isn't advancing. I'll try on that button. Is that working? Yeah, this is my conflict of interest. I am a Mertz speaker, and thank you to Mertz for inviting me and to Bangkok. So going on a little bit from what Ting's song was, this video's not running. Could you run the video, please? We're talking about extracellular matrix. It is part of an ecosystem at a microscopic level. It's made up of three things: the cells, the extracellular matrix structure, and also biocues. And they're very interdependent. The key thing, this is supposed to be moving. Oh, the battery ran out. Can you just flick that video on, please? Okay, just pretend the video's running, imagine. And we have an extracellular matrix, which is three-dimensional, made up of collagen, elastin fibers, and various aminoglycans in it. The cells attach to that structure. This is the key point you need to remember. They attach by integrins. That structure in the video, which is not running, is supposed to be moving, dynamic. All extracellular matrices, they're not static. Even the bone moves a little bit. It's got tensions. And the cells respond to those tensions and that movement. And each cellular population responds to different tensions. So in the dermis, they're used to it springing back. In the fat, it's flowy. In the bone, it's tense. The integrins, which are the parts of the cells, no, we're right now, don't touch it, please. The integrins attach to the proteins of the extracellular matrix. The force is transmitted through the cytoskeleton, through the actin myofilaments to the nucleus, which upregulates. It's a very quick system. It's far faster than a biocue sitting on the cell membrane. So for an extracellular matrix to be functional, one, it's got to have this dynamic flexibility that matches tissue structural requirements. It has to allow cellular attachment and have an environment for the cells to thrive and proliferate. It itself provides direct cues to the cellular population, and also, of course, it's got to allow nutrients and diffusion of messengers to come through the system. If we get it wrong, if the extracellular matrix is not right, such as in aging, when we get glycosylation of the proteins and it becomes a little bit more fragile, a little bit more stiff, the cells are sort of not going to respond. They don't work as well. And then we see all sorts of problems and disease. So if we're going to regenerate an extracellular matrix, all right, we're thinking this is part of an ecosystem that supports the containing cells, we have to think about the tensions and fluidity, a little bit on what Ting Song's been explaining. We need to get all the components of the extracellular matrix there, and they need to be in the right ratios and the right architecture. If we get it right, then we're going to see it clinically. We're going to see the tissue health improve. And that's going to translate for us as aesthetic guys into an improvement in the aesthetic appearance of health and vitality. How do we do it? This is the big question. So if we think about regenerative aesthetics and regeneration of tissues, there's three elements: cells, biocues, and biostimulatory scaffolds. So I'm going to skip the first two and go straight to scaffold. Because what is a scaffold? By definition, it's a three-dimensional matrix that mimics the biophysical cues of the extracellular matrix. So it's those things that the cells sort of like, they're going to click on because they recognize the chemistry, they recognize the physical cues, and they will attach. And they sort of get conned into thinking they're into extracellular matrix, and they will start to behave appropriately. So that's what we're going to try and aim for. This, on the bottom right, is a calcium hydroxyapatite microsphere. You can see fibroblasts actually attaching to it. And this is the key differentiator between a ceramic ionic calcium hydroxyapatite and a polymer. There is a spectrum of biostimulators. They are not all the same. They behave differently. I haven't got time to go into it, but simply, when we talk about biomaterials, they fall into three classes: metals, ceramics, and polymers. Well, we don't inject metals in the face, so we're down to ceramics and polymers. The only ceramic we use is Kaha. Polymers you'll be familiar with, polycaprolactone and PLLA. I've had a long day. So the difference is ceramic, ionic, crystalline, look familiar. The cells don't respond in an inflammatory pathway. If you have something that is completely not meant to be in your body, polymers, then your body is going to, or your immune system is going to try and seal it off. And that's a foreign body response. It's an inflammatory process. It produces collagen, it produces elastin, but does it produce a dynamic, flexible extracellular matrix? I will argue, no, it does not. And we have studied this in the lab, and we put the ceramic Kaha and the polymer PLLA up with macrophages just to see what the response was, because the macrophage is the key number one cell in this process. We had inflammatory cytokines in response to the polymer, but not a beep out of the ceramic. And you can read more about this in this paper that we published a couple of years ago. We can make all these proteins, sure. We can drive those fibroblasts and start pushing out proteins. Is that an extracellular matrix? No, it is not. It's a provisional matrix. This is when you go back to the wound healing principles: thrombus, inflammation, proliferation, remodeling. So we can biostimulate, we can stimulate those fibroblasts, get all these proteins, but they've got to be remodeled into an extracellular matrix. It's got to be broken down and put back together in the appropriate way. So I've been working with two of my colleagues, Kate Goldie, Gabriella Casabona, and this is a study that we've just published a couple of weeks ago. We injected an abdominoplasty patient with different biomaterials and biopsied it 6 months, 3 months, 14 days out to see what was going on. And this was injected subcutaneously in the subcutaneous fat. We saw collagen, as you expect, boosted it mainly at 3 months, dropped back at 6 months as the remodeling process is occurring. The proteoglycans decorin followed suit. It's important in the extracellular matrix deposition and a signaling molecule to prevent fibrosis. It's also important in fibrinogenesis. We saw those the collagen and the decorin boosting mainly in one-to-one mix. Elastic fibers, again, we get the protein boost with the provisional matrix at 3 months, coming back at 6 months. Meanwhile, fibrillin 5, which is the little molecule that is important in fibrinogenesis, the proteoglycans for that, starts to peak at about 6 months as that remodeling is occurring. Versican is another proteoglycan important in fibrinogenesis. And in this provisional matrix, it's an important proteoglycan. Again, it comes out strongly at 3 months and drops back by 6 months. When you looked at the histology, you see at 14 days, we saw that dense collagen fibrils around the CAHA molecules. At 3 months, it was the microspheres are beginning to fragment, but we're still seeing a lot of dense collagen. But at 6 months with the remodeling phase, we're now getting that looser basket weave collagen that we normally see actually in dermis. And also we see the increased vascularity. See all those little capillaries there are appearing. This tied in clinically when Gabriella ultrasounded the skin and saw an improvement in elastosis. So you can see that's a lucent band between the epidermis and dermis. And that improved after the CAHA treatments, mostly in the 1-to-1 dilution. She also saw an improvement in skin thickness, mostly in the 1-to-1 dilution. So there must be some kind, which we've got to work, we've got our theories about paracrine effect, because this was injected subcutaneously, affecting the dermis overhead. The main take-home message is we are seeing this remodeling phase towards an extracellular matrix. So that's why we're considering CAHA CMC a regenerative biostimulator. It provides the physical and biochemical cues to the cells so they can upregulate. It's an avoid an inflammatory foreign body pathway, which the polymers follow. And they primarily give collagen and all the other proteins, but they have the potential to stiffen the matrix and, to be honest, can cause fibrosis. So the evidence that we are beginning to show is that we get remodeling this provisional matrix into a mature extracellular matrix. And you ultimately see the improvement in tissue function, which shows it's working. Thank you for listening to me.
Thank you so much, Neil. Next, we'll have Dr. O, who's going to talk about PLLA and against all the others, so generating even more controversy.
Actually, title is not my idea. Before my presentation, I'd like to ask you, don't take a picture and a video for my lecture, because a lot of patients' face on my slide. In Korea, there are a lot of sue from the patient, please. And the second, my answers are not come from a paper. My answers come from my patient's result, okay? So this patient is 53 years old woman who visited my clinic with concern about nasonavial fold and mid-cheek volume loss and dull-looking skin. I choose Sculptra, a PLLA, is injectable as treatment modality. PLLA is safe, biodegradable material made from a natural source such as corn. Sculptra has a unique semi-crystal structure and physical properties. This is not a company-sponsored lecture. This is my will. So it is well known for its ability to stimulate collagen production. So I choose Sculptra as the sole treatment modality. No additional boosters, fillers, or energy-based devices were used. By the third treatment of session, just 2 months after first injection, she showed a remarkable improvement. 2 years later, 3 years later, 5 years later, 6 years later, 7 years later, 8 years later, and 9 years later, 11 years later. This patient continued to receive Sculptra treatment and remained under follow-up until last year, a total of 13 years after her initial treatment. What do you think about it? So many doctors ask me, there are so many skin boosters today, why do you still use PLLA? So today I will explain the answer in 5 key points. My first reason for choosing Sculptra is its long 26-year history. The first product was introduced in 1999. It received FDA approval for aesthetic use in 2009. The main concern with the PLLA is a nodule formation. Through years of experience, we learned that the polymer need adequate hydration before use. In the early days, PLLA was reconstituted with only 3 ml, but today it is commonly diluted with 8 ml or more. We found that increased hydration volume significantly reduced risk of the nodule formation, right? The key of PLLA hydration is not how long you wait, but how evenly the particles are dispersed. However, short hydration with insufficient mixing may lead incomplete hydration and increased risk of nodules. So the second reason I like Sculptra is my long experience with it. I started use Sculptra in 2011. It was first approved in Korea. Doctors get older, my patients get older too. So my patients are aging along with me. As more patients seek anti-aging treatment, I have needed options that provide natural looking and a long-standing result. So Sculptra is known to provide a long-lasting result with effect that can be last for more than 2 years. These photos were taken before treatment and 2 years later. Improvement can be seen in volume, wrinkle, color, and skin quality. This 62-year-old patient was photographed 2 years after treatment. Such a long-lasting result are not easy to achieve with EVD or other injectables. Sculptra was originally used in HIV-associated facial lipoatrophy, making it especially effective for hollow cheeks in men. The third reason I prefer Sculptra is my long experience with it. I would like to share the clinical result of 47 patients who were followed for more than 2 years after Sculptra treatment. My PLLA protocol consists of 3 sessions at 1 month interval. Patients are re-evaluated at 6 to 12 months, and 1 additional vial is used if needed. The result can be lasted up for 2 years, followed by maintenance treatment with 1 vial per year. This patient came at the age 45 saying she looks too masculine, so she wanted softer, more feminine appearance. Sculptra was chosen, and this is her 5 years follow-up result, more feminized. Here is the similar case with a 5 years follow-up. She looks almost unchanged during the 10 years. As maintenance treatment continued, the number of the vial gradually decreased, often become lower than a recommended protocol. We do not need large additional dose during follow-up. The collagen regeneration by accumulated PLLA remains stable for a long time. The fourth reason I prefer Sculptra is that as a dermatologist, I can use it for various skin conditions. Here is the case of Perry-Romberg syndrome with progressive facial atrophy. PLLA produced remarkable improvement in this patient. I have followed her for 10 years with occasional maintenance injection, as results have remained stable. Even with only 2 PLLA treatments, remarkable improvement can be seen in patients with lipodystrophy. Linear scleroderma on the hand and arm is challenging to treat. Even so, encouraging improvement was seen 8 months after PLLA treatment. Finally, I would like to discuss side effect and concern. I'm not very concerned about nodule formation. My main concern is fibrosis. It's today's topic. Some plastic surgeons reported that during the facelift surgery, patients previously treated with the Sculptra may show the fibrotic changes and inflammations, making the anatomical layers more difficult to identify. In fact, the same question could be asked after facelift surgery. What would we find if we open the tissue after the facelift? Although their mechanism differed, HIFU, RF, PLLA is all share the common anti-aging pathway. It is regenerative wound healing process induced by the controlled tissue injury. Fibrosis is not always bad. The key is whether it helps the tissue regeneration or causing scarring. Monocytes migrate into tissue and mature into macrophagy. Depending on the envelopment, they become either pro-inflammatory M1 macrophages or pro-healing M2 macrophages. The balance between them determines whether inflammation or regeneration occurs. During the wound healing, M1 macrophage dominant in the early inflammatory phase. As healing process, they switch to M2 macrophages, leading to tissue repairing and remodeling. PLLA initially induced the foreign body inflammatory response, but it does not maintain the chronic inflammation. Instead, it promotes regenerative healing process through the M2 macrophage switching. But excessive or repeated PLLA stimulations may shift the response from the regeneration to pathologic fibrosis. Some physicians describe, like Ting-Song Lim, described excessive fibrosis and internal scarring caused by repeated stimulations as facial interstitial fibrosis. This can occur with both injectable and energy-based devices. Excessive fibrosis may impair the tissue quality and contribute to accelerated aging over time. The ultimate goal of PLLA treatment is controlled fibroplasia. This requires proper patient selection, appropriate dilution and dosing, and adequate treatment intervals. I do not choose treatment because it is brand new. I choose treatment that has proven reliable and delivered consistent result over many years of experience. That is the essence of medicine taught by our mentors. Thank you for listening. See you in Seoul this December.
Thank you so much, Dr. Oh. That's a great clinical experience and lovely results. Our next person will be Dr. Kim, who is for ADM and against PCL, and we're hoping to know why.
Hello, everyone. My name is Jong-seo Kim from Korea. I'm a plastic surgeon. Okay. How can you stimulate the collagen formation? And then which type of collagen is most beneficial for the ECM remodeling? The PCL was the fascinating material. Once injection into the tissue, the body recognized as a foreign body and the triggering reaction, and this response stimulate the fibroblast activity and collagen production. The most of the time, the result is beautiful collagen regeneration. However, in some patients, the response can become excessive. The prolonged inflammation may lead to the excessive collagen deposition and make foreign body granuloma, sometimes the nodule, and then sometimes the fibrosis. This is my case. I'm injecting the PCL into the subdermal layer using the cannula. During the injection, the cannula is moved back and forth repeatedly, so many strokes to create the controlled micro-injury, while the even distribution to prevent nodule. This is before and after, although the product is injecting only one time, when the new collagen is gradually and continuously synthesized over time. Sometime over 4 years. As a result, the skin became healthier and the dermal ECM became stronger. The skin quality continues to improve over time. In addition, the noticeable the volumizing effect. This is my second publication, of the PCL. One injection, but years of regeneration. In selective patient, I use a microdroplet intradermal injection technique in this patient. Over time, the skin texture became smoother. Elasticity increased, the overall skin quality and skin pore improved in this case. Also, this is my article, the fibroblast activation, neocollagenesis, dermal rejuvenation after PCL injection. This is first article, human biopsy study of Lancet PCL, which I published in 2014. At the time, I considered the controlled foreign body reaction to be the key, the driver neocollagenesis. This is my third article of the PCL. Through the serial human biopsy for every year, I confirmed that the PCL can persist for up to 4 years. The long-lasting result is very impressive. However, there is the catch. The longer persistence, the greater the potential risk of complication. So some case like this, PCL may induce excessive progressive collagen formation, leading to the nodule, fibrosis, yellowish, the mass. So PCL is a double-edged word. So when it works, it increases the beautiful regeneration. When it goes long, it can be cause fibrosis, granuloma, and huge mass. For this huge mass, I remove the PCL material. Sometimes we inject 1 cc PCL. The resulting was excessive 5 cc. So I surgically remove 4 cc of excessive tissue. This is also another complication, large hard mass formed on the eye and conform to the enlarged progressively every day. This is also another case after PCL injection. She can complain about the huge mass. They inject 1 cc, but the mass, the amount was more than 10 cc. So this is ultrasound image revealed that huge mass in subcutaneous tissue layer. And then I checked the blood vessel, and then mapping, the blood vascular mapping was performed before the surgery to identify the vessel and ensure the safe excision of the lesion. This is after surgery, I removed the nodule. And then I did a biopsy study about this nodule. Instead of physiologic neocollagenesis, excessive foreign body reaction, you can see, and then you can see the many giant cell and too much collagen, too much fibrosis. This is another stain, here which is staining. You can see the new collagen, stained blue. You can see the collagen 1, stained red. Too many collagens, that's after PCL. So collagen 1 and 3 is being produced continuous, growing without stopping. That is the problem. So liquid PCL has also been released in these days. But liquid PCL did not form excessive large mass, but instead, some patients developed a persistent bruise-like discoloration that remained for a long time, did not fade. Normally, the bruise gradually fade out, hemoglobin and hemosiderin, and then cleared by macrophage. However, the PCL induced fibrosis, liquid PCL, and may trap the hemosiderin within the new formed collagen fibrosis, so preventing its normal clearance. So the bruising lasts longer. So compare the polymer and the ADM. Now let's look at the alternative skin booster. The ADM is the acellular dermal matrix. It's 100% our tissue. The immune cell feels the smell familiar. So no chemical, no plastic smell. It is like our earth. We don't need to fighting, no foreign body reaction. We just need to remodeling. Sometimes implantation. So, what is your choice for your skin? The upper side is a fake plastic and some polymer. The lower side is natural, the human skin. So this is my book. I wrote the book about ADM filler. And that is the oldest ADM filler. The 2004 already, Symetra is a micronized ADM product was already being used. This is new ADM filler made by Korea. It's the most common used ADM. It's a retool product. Also, this is a Megadom. It's an ADM sheet we implant using the surgery. I have been using this Megadom sheet for nose instead of silicone. I used more than 13 years, clinical place. I did the overlap imaging. You can see the augmentation amount. I analyzed the 3D analysis. This after the 13 years later, still remained. Also 13 years later, I check up the ultrasound. The ADM was still remained like this. It's my article. So 5 millimeter height ADM remained almost 4 millimeter even after 13 years. Next topic is the scar. So what about scar using the ADM? ADM can also improve the scar. So I inject the ADM very superficially to cover the scar tissue. So before after, I like to inject the ADM to cover the scar like this. This is very easy and very effective. The concept is very simple. Instead of treating the scar, we place ADM over the scar tissue. I can say that masking the scar with healthy dermal tissue. I also inject subdermal layer near the dermis. ADM is actually rebuild the soft tissue under the dermis, providing the healthy extracellular matrix. Every evening we go home to rest. So what if you did not go home? We cannot live, we cannot sleep without home, right? So we need the home. So human is the organ of fundamentally composed of two components, the cell and ECM. Cell is like a human, ECM is like a house. We may separate them conceptually, but biologically they are functional as one, the proper together. So left side is homeless, so we need the house to sleep and clothes, medicine, a space that protects us, supports us, keep us alive. Without house, the survival became difficult, sick. So cell is human, the ECM is a house. So when the damage of the ECM, as a result, the fibroblasts lose the structural support and they collapse, such as the homeless became sick. So good environment, the ECM makes cell healthy anywhere, face and neck and hand. I like to inject the ADM for the intradermal injection using the injector, the eye for the eye. For the skin, the dermal injection is good. So I believe the ADM will become the best skin booster in the future. Don't be late to the party. I'm Jong Kim. I love to use ADM. Thank you.
Thank you so much. Are you ready, Achima? So our next talk is Dr. Achima Chinda, and she's going to talk to us about polynucleotides.
เปิดไฟหน่อยค่ะ ปิดไฟให้หน่อยค่ะเปิดไฟให้หน่อยค่ะอ้าวแล้วตัวเองไม่ใช่แผนก AV เหรอเปิดไม่ได้เพราะว่าเสียบไอ้นี่ไงเสียบแล้วเมื่อกี้ที่บอกเพราะว่า Sorry for the delay. My file crashed this morning, so I couldn't retrieve.
Are you about ready to start, or are they just loading? Achima?
Sorry.
So I think there's a little bit of technical difficulty. Anybody in the audience have any questions? Strong opinions, controversies you'd like to share? What about you, Niam? Are you using anything other than Kaha for biostimulation?
No, I'm not, because to me, to use an inflammatory pathway of a polymer doesn't make any sense when I'm aiming to get healthy tissue and create an extracellular matrix as close as we can. Whereas if you're doing an inflammatory pathway, you're going to get all the collagens, you're going to get elastin, but I think that works just by volumetric changes and also tightening up deep tissues, which may be having a transmitted force through to superficially. But I still don't like the idea of putting inflammatory products into the tissue if we can avoid it. That's just me. I do like the idea, and I think it's huge potential of ADM. I mean, I remember when we used to use it in breast. Yep. We still do. And it makes a lot of sense because what you're trying to do is give the cells something to attach to. It's conning them into thinking they're in their own environment. And the more you can do that, the more you're going to avoid an inflammatory process. It doesn't mean that you're not going to get an inflammatory process with ADM, or CAHA. I mean, there's other things that you can do. Traumatic approach, getting contamination, that's all going to make them go down an inflammatory pathway. So technique is very important. But I certainly think ADM sounds a very good way to go.
I think so. I think it's basically an emerging technology again. It's been around for a long time, but I think, Ting Song, what do you think about particle size? How important is that?
Well, a lot of times when we look into the living tissues, there's a lot of space. Anything that occupies space can actually disrupt these connective tissues. And therefore, I think when you have more of these bigger particles, of course, it clumps together, it creates a foreign body reaction. And this is where we get into trouble. And I think we are moving towards extracellular matrix replacement therapy. How I see ADM, SVF, nanofats, they're basically breaking down all the tissues and just get the extracellular matrix. We are feeding the extracellular matrix with food to rebuild itself. And this is what we see with, of course, Achima will talk about polynucleotides, and now we also use collagen. It's all part of this whole extracellular matrix replacement therapy, or we just enhance them by giving all the nutrients and let them rebuild itself. And I think this is where we actually need to approach, rather than thinking back into putting volumes or fillers or trying to occupy the space. Why don't we make the extracellular matrix healthier again?
Yeah, I think that makes sense. I think all of us, because it's a regional approach too, all of our solutions are not available all over the world. And so we try to make things work, try to avoid fibrosis. One last question I had for you, Neil, while the team is finishing up, is I saw that your dilution ratio was really pretty low. I know Sonia uses a 1:3 ratio for CAHA. How did you choose the 1:2?
We did 1:1 and
1:1.
1:2 because clinical papers have indicated that 1:1 seems to be the most regenerative effect and in clinical improvement in face. So we were looking at that and 1:2. We didn't do any further dilutions, but certainly. But remember, and I think it is very tissue specific, this was in abdominoplasty patients, which may be different to face, which may be different to hands. I think there's going to be subtle differences because each tissue varies. So, okay, Achima is ready.
Sorry,
right. Here we go.
Okay. Sorry for delay. I did my slides. It just crashed, and then this is my final repair. So final repair file. I have to redo everything, but hopefully it's okay. So there are many aging ways besides fibroblast senescence or microvascular decline, including adipose progenitor exhaustion. You also have a major pathway, which is ECM disorganization, and that's why we are here, because at the moment we try to find which will be the best way to define the healthy ECM or regenerative ECM. So what is the ECM? It's before we believe the ECM is like, the inner passive space that will fill with collagen, elastin, fibronectin, hyaluronic acid, glycosaminoglycan, but it's not just that, because ECM is a 3D living mesh that actually kind of destine the cell how to behave. So, the ECM is not just about the cell or where the cells sit, but it's actually about the environment that they built and inhabitat. So it's actually a very important structure, because it instructs the cell whether it will turn into scar tissue or it turn into healthy tissue, or we regenerate newer tissue. So this is actively regulate cell survival, including cell migration and also differentiations. The important mechanism, which is a mechanical mechanotransductions. So when we're talking about ECM remodeling, it's involved in cell matrix feedback process, which is involved many cells like fibroblasts, macrophages, endothelium cell, also others, protease growth factors, and other biomechanic. And this is the cell respond to injury, including cytokine, interleukin, tension, matrix stiffness that I'm sure that others, previous speakers already mentioned about it. And, but this remodeling actually requires a balance between synthesis and degradations, and also control together with the collagen elastin associated protein, fibronectin, hyaluronan, MMP, TMP balanced, and also macrophages, endothelial cell, keratinocytes, and this session that I'm talking about is actually about polynucleotide, but I would like the audience actually differentiate between polynucleotide, PN and PDRN. It's actually not the same. It's a little bit similar because it's based the same on the DNA polymer, but it's different structures. Because in PN, you have a longer chains of DNA fragments with a higher molecular weight, or more than 1,500 kilodaltons. But PDRN, you have shorter chains, you have less molecular weight, And also the physical properties are really different. In the PN, you have a high viscosity, and you have high water binding capacity. And so with these physical properties of PN, it can form a cohesive hydrogel with hydrations, good hydration, including the structural support. And the primary mechanism, because of those structures are actually different, so it's showing the primary mechanism of action. Both are different. So PN provide more kind of physical scaffolding, and with the intense hydrations, but with the PDN, it's more like pharmacological drug. So I think this is the important slides that telling the differences between PN and PDRN. As mentioning, even though it's a DNA-derived biopolymer, but its structure is different. With some structural similarity, but they are different in terms of physical properties. So when we look at PN, we look at it as more scaffold effect. Even though it's a weak scaffold, it doesn't really like the others physical scaffold products, but it has a scaffold effect. It has scaffold products. So the primary mechanism of actions of the polynucleotide has a key role in structural ECM remodeling because of that scaffold structures. That's why PN can categorize into the ECM remodeling products. But with the PDRN, it's working different. PDRN, it has no scaffold at all. According to the publications that has been published, looking at the EM of the PN and PDRN is really have a big difference. So PDRN is more like pharmacological drug, and it doesn't have scaffold, and that is the major differences between those two. So, but again, PN is also different from brand to brand. Some brand doesn't publish that they have a scaffold. They hasn't really mentioned, but because this scaffold effect really make a difference because it resemble, particularly the one that published. This scaffold has a structure which resemble a native ECM. It has been mentioned about it like 10 years ago, they're talking about this scaffold as a biomimetic scaffold. So with these biophysic properties of the PN, so it's more like, it show like 3D scaffolding, so it show biotensegrity property, which is really important because this will affect the mechano sensing that will give a physical fibroblast spreading and leads to a ECM remodeling, which is different from the PDRN, which is more on the biochemical properties and leads to the molecular reprogramming. But those two also creating ECM remodeling, but in the different mechanism of action or mechanistic action. So look at the PN scaffold. Sorry. So the architecture of the PN, we call it 3D polyhedral tensillations. So these structure has a distinct structures with the size around 3 to 8 micrometers and very thin continuous wall, tightly tensillated with no gap. And the geometry of the structure scaffold is more like a pentagon and hexagon. And this is structure that we call biotensegrity. And they have a name of this geometry as the Weir-Phelan geometry. And this geometry is really important because it's giving a mechanical efficiency, and also it's give the cell to be able to attach with the fibroblast very efficiently. Because as we know that when the age fibroblast, you're losing, all the web of the fibroblast, it's losing all the spindle cell appearance. So it's more like a round cell. So that's why it's you losing the activations of the tensions through the fibroblast. So you less create of the collagens and don't be able to stimulate signaling or biochemical, pathway when your fibroblasts are aged. Okay. And also with the PN, it builds a living scaffold by promoting other collagen matrix via several of mechanism of actions, like via ERK, via MMP, and also with a structure which is intensely hydrate the skin, so it can stabilize the extracellular space. Yeah, it also goes through the mechanical kill, which is retune fibroblast mechanotransductions through the FAK and YAP and TSE axis. This is important for ECM remodeling. Okay, it's mechanical actions. And this is the trophic reservoir effect is because of intense hydration, so it helps to control biodegradations of the collagens and elastin and also repair of the tissue. Okay. All right, so basically, I will conclude, of the effect of PN scaffold function in one slide, that it helps, to ECM remodeling by a different mechanism of action, through the it's helped to create new collagen type 1 and 3 deposit, and also help to support angiogenesis, and with the hydration, improve hydration and viscoelasticity, and it also shown that it helps to increase mechanotransduction and help to balance the ECM stiffness, help to prevent fibrosis and promote a balanced ECM remodeling.
Thank you very much, Achima. I think one of the things that is an overall controversy that I think still remains is, are the effects of biostimulators clinically good enough for us not to have to worry about restructuring the scaffold, or should we, as Ting Song said, try to restore an elastic, proper tensile strength solution? And how can we stay out of trouble with biostimulators?
Sorry?
How can we avoid fibrosis with biostimulators?
How do we avoid fibrosis? Well, for me, I think, number one, you don't use a polymer. Number two, I think we have to consider that when you inject, you create localized trauma, and that releases damage-associated molecular patterns which stimulate tolerate receptors on the macrophages. Also, if you get any contamination, so I always am very concerned when I watch injection demonstrators and people are touching their hair, touching the face, there's not sterile gloves, because all you need is a tiny bit of contamination, not enough to cause an infection, but contamination that will stimulate tolerant receptors on the macrophages. As soon as you do that, then they go into an M1, M2A. So when you look at M2 macrophages, there's M2As and M2Cs. M2Cs are the more the regenerative. M2As are the ones that drive the fibrotic response that we see with polymers. So you're going to, even if you're using even ADM, and you're not really careful about minimizing trauma, minimizing contamination, you're going to drive it an inflammatory process. So it's not so simple and straightforward as just grabbing a syringe and shoving it in.
I think it's also related to frequency of, when you're doing procedure. Because it has to, the skin have to wait a little while, before it remodel the ECM. But if you do too soon, instead of, creating through the channel of regeneration, it will go through fibrosis.
Absolutely.
Yeah.
In our study that we've just done, showed that we got the provisional matrix at 3 months. And we only snapshot at 3 months and 6 months, but certainly at 3 months, we're very much in the proliferative phase. And it took 6 months to actually see that remodeling process taking effect.
Yeah.
So
Yeah, I think the clearing up is slow, then you actually accumulate more. It actually is space occupying and it's a foreign body reaction.
Yeah.
But the other thing that I will want to add on is I feel that we should avoid damaging connective tissues when we go in, either by needles or cannulas. We've seen people using cannulas that just scrape off the whole connective tissues as if that doesn't function, because all these are functional connective tissues. The other thing is injecting superficially. I think always problems happens when you go into the dermis. I think we should stop injecting into dermis and
You
go
think
deeper.
so?
Yes. I feel that we get into trouble because tissue expansion in such a way, especially if we bolus it, stretch and create cracks. And at the same time, it injures the connective tissue in a certain way. And therefore, we tend to see, even in the early days when we do PRP, when you actually do multiple punctures of the skin, especially Asian skin type, I tend to have patients getting more sensitive skin in the end rather than getting more rejuvenated. So I feel that sometimes we shouldn't injure too much because it's a barrier. And this barrier has lots of cells that helps to protect the skin, and if we injure too many times,
What's your
that's
idea?
my thought.
I agree. I think that too much trauma is pro-inflammatory. And I think if we want to be regenerative, we have to be gentle, we have to be nurturing to the tissues. And it's just a change. Like when I first learned to use Kaha, theory was that you'd be activating where the fibroblasts are, so you'd be scraping it along under the dermis. Now we know that it's just not on. You need to be just gentle little subcutaneous gliding and very gentle, causing minimal trauma.
Okay, may I have a question? So,
One more. My idea is the most important thing is first dosing. I usually normal the 1 vial per 1 session. And then second is interval.
I think interval.
Yeah. Is
Frequency.
I have changed every time. In the beginning and nowadays is a lot of things are changed. So at the beginning I usually do the 4 weeks intervals, but nowadays over 2 months or 3 months. We to check the patient's state of the skin. Yeah, technical something. It's minor things, I think.
It looks like we have a question from the floor.
yes. Okay, thank you so much. I'm Dr. Sarita from Bangkok, Thailand. I want to ask about the recommendation because nowadays we have a variety of skin booster, skin biostimulator, and regenerator. So, how we should choose which product we should start first in the indication of maybe the age or skin quality? Would you please have a guideline for us? Thank you so much. Start with inflammatory or non-inflammatory in the elderly or something like that?
I think some of the skin boosters are basically dilute fillers, especially the European products. They're basically just dilute HA. And I think while HA can be a biostimulator, it doesn't really work in the same way that the topics that we've brought up. And so my personal feeling, I'm more of a Chima or Tingsong, scaffold, support, regenerative type of person, because we want something that will be a load-bearing scaffold and something that decreases tissue fragility. I think certainly to a great extent, Kaha will do that as well. I don't have much experience with PLLA because the experience that I had early on in the US was that it was very difficult to get it to dissolve and not precipitate out and not create nodules. And I know there's a newer version, but you know, once you have that experience, you don't want to repeat it. Have you had that same experience, Dr. O?
There are a lot of things, but it's hard to compare the skin booster and a skin biostimulator. I think my idea is a total different one, right? So my patient has want a more volume reduction or volume augmentations. I usually recommend a stronger one. PLLA is I think is stronger. But she's younger and more skin quality one. We call it the skin booster. PN or Retool is ADMs. So it's hard to compare which one is better to the patient.
That's why some doctor like they mix like do like alternate thing, like start with maybe PRA and then shift to PN or something else. So what is the proper gap between each treatment? The previous session they talk about like if you start with something such as Scalta, you just wait until maybe for a while until like, you can see the full result, or maybe it should be 6 months as you said. I'm not sure, but is it necessary to mix the thing like but
Right.
orderly?
Yeah.
The recommendation I
So
just want to know.
PLL is stronger though, but the response is so late, so slowly. So if they want a more immediate effect, I usually recommend HA or KAHA first to the patient, right?
You want to take it? So my take, I feel that sometimes there's so many things in the market, so everybody get confused. But there's one thing that we always want to do: make sure that ECM is a healthy condition before we stimulate them. So my approach is giving them the nutrients. Nowadays, there's a lot of things that contain certain types of nutrients. You can start out with that first. Make sure that the whole body is rested well. We heard earlier, if your body is very inflammatory, anything put in, especially in big amounts, will end up either no results or you get complications. So let it be energy-based devices or injectables. We always go. The whole tissues has to be healthy before we do anything. So that is my take on it. Yeah.
I agree with the Ting Song. I think that should be a take-home message.
The one proviso I just want to add is this thing about mixing in a syringe. When we mix things, we change that pharmaceutically. When we're talking about biostimulants and biomaterials, the way the immune system responds depends on multiple things. The rheology, if it's got a high G prime, you're going to push more towards a foreign body response. If you change the pH, if you change the electric charge on the surface, if you change the hydrophilicity, that's going to change the way the proteins lie on it and change the whole cascades. So we have to think, and this is why pharmaceutical companies and the manufacturers are loath to mix things in a syringe and just give them to you, because we know it changes how products work. So we just have to bear that in mind, and just in immunology, 1 and 1 does not equal 2. I think that's what I'm just going to say. We just don't mix things and expect an additive outcome. You need to be careful. I also agree with Ting Song and Achima that think about what we're trying to do. We've got a fragmented, fragile extracellular matrix. We've got aged cells. Nutrient support to the cells, reduce the inflammatory environment, which is often an integrative approach. And then when you've optimized the system, then you may stimulate, but stimulate as much as you can down a regenerative pathway, not a foreign body inflammatory response. Apologies to my colleague over here.
That's why we should prime the area with the PN first.
Yes. Yeah.
Yes.
Absolutely. I think,
So
priming.
priming with PN or even the amino acid.
Can I ask you, does PN, because I break
Yes.
down into PDRN, or
Okay.
acts the same way?
Okay, yeah.
It does.
Well, I believe that it does. We break down, but that's why I say primary mechanism of
Yeah.
action, not the well. But you know, when it has a weak scaffold, it definitely has scaffolds, and
Yes.
that scaffold is actually affect the way that mechanotransduction
Yeah, sure.
and
Yeah.
sensing. So, in the beginning, it's come as a scaffold structures, but then it will
So it
go
does,
into PDR, I believe.
you believe.
Yeah.
Is there evidence for that?
No.
So let me just put it that way because the company that actually did polynucleotides, they actually started developing PDRN first as a replacement of initially using placenta.
Yep.
So they found that in human placenta, which was banned in Europe, they realized that if you get the substances from gonad of a trout fish, they actually get similar components, which is the components of PDRN. But PDRN, like what Dr. Achima mentioned earlier, it breaks down so easily, and then the effects goes away. So what they did was they decided to chain them together, just like when we have our DNA, which is a chain of nucleotides anyways, and also ATP, GTP, they are actually nucleotides. So because not only they are chain of genetic materials, they are chain of raw materials for our energy. So basically, when we actually place in there, because to get into to register as a medical device,
Yeah, I
they
know
have
that
to
story.
sell the idea of scaffolding.
Yep.
But in fact, they cannot say this is a medicine because then it has to be registered as medicine. So therefore, I think the whole story of scaffolding is there, but I still feel because all polynucleotides or oligonucleotides, we have enzymes to cut them into pieces.
Sure.
And in the end, it will end up as nucleotides that feeds the nucleus of the cells and our tissues to live better.
And so the breakdown products of polynucleotides will stimulate the A2 receptors and actually do those repair processes within.
Adenosine, yeah, ATP
It
receptors.
will repair.
Yes.
Even though we don't have the evidence.
Yeah.
Or published
Well,
evidence.
Yeah, yeah. I mean, the reason that they make it as a longer chains and with the higher molecular weight because they want the effect to be longer. But if you, particularly like when we're talking about intense hydration effect, it's more on the PNs, not the PDRN. Because that's a scaffold effect, that's why you have intense hydration. And we need intense hydration in ECM remodeling. It's a different mechanism of action. I wouldn't say that PN equal PDRN, I wouldn't say that. It's sharing similarity, I mean sharing some similarity, but it's not exactly the same.
Okay.
Yeah, I would say that.
Thank you.
Yes, any questions from the floor?
To close it?
Yeah?
Let's close the session.
All right.
We could be here all night talking about this.
Well, thank you very much, and thank you for having
Thank
me.
you. Thank you. Thank you to stay there.